Hi everyone, Hunter Hicks. Today we're going to be looking at cataracts, glaucoma, objective, subjective data, diagnosis, and treatment. Really how our vision works in a nutshell is light needs to pass through and get all the way back to the optic nerve so we can interpret the data. Well, it's got to pass through the cornea, which we know is going to cover both our iris, the color portion of our eye, our pupil, through our aqueous humor, through the lens, through the vitreous humor, and back to the retina, back to the optic nerve. Anything to come between that, which we're going to talk about today, cataracts and glaucoma, can affect our vision. So first, cataracts. Cataracts is really going to affect the lens, and it's going to affect the lens, like clouding on the lens. So the lens sits behind the iris again, and the lens really is made up mostly of water and proteins. And overall, as we age and other risk factors that we'll talk about, what can happen with those proteins is they kind of like aggregate and kind of clump up, right? And wherever those proteins clump up can or cannot affect the patient's vision, right? So some cataracts, some of these proteins like to sit more in like the central vision area, like our nuclear cataracts. Those can have direct effect on these patients. Some sit more on the periphery, so they might not have much effect on the vision at all. Just depends on the acuity and really sometimes where they are and how bad they are. Cataracts overall is going to kind of be a progressive thing we're going to see in older patients, but things that can increase your risk for cataracts are patients that are outside, a lot of UV exposure, right? So maybe a lot of outside workers, stuff like that. Also patients that are taking chronic steroids, radiation, all these things can increase your risk for cataracts. But overall, we start to see some cloudiness in that lens, and that can overall affect our patient's vision. So when we look at the assessment, these patients can be totally fine, right? Because even with some cataracts set in, they might not even have issues with their visual acuity assessment. But some things they can complain about is maybe farsightedness, nearsightedness. Another common thing they might say is like a glare they see either during the day or at night, like a really bad glare that they see during the day or at night when they're driving. Those are some things that we can kind of see with these patients. Now, the ultimate treatment is really going to be surgery, obviously done by a professional. But when we look at the options for patients to have surgery, the biggest thing is we have to ask ourselves, ask the patient, what is this effect of cataracts on your activities of daily living, right? That's really the big question that needs to be asked to see if surgery needs to happen or not. Obviously, some patients can have cataracts and it doesn't really affect their activities of daily living, and they might not need surgery. But if it's affecting it, obviously, surgery is a great way to help this out and hopefully fix the cataracts. But if not, we need to understand that sometimes people know that there are risks for cataracts, or just how do they might have the question, or other people just want to know, how do I lessen the progression of cataracts? How do I protect my eyes now? So overall, when you're outside wearing hat, wearing UV protected sunglasses, right? So we know they're UV protected, so protecting your eyes. Sometimes there's special glasses we can prescribe patients that maybe have the diagnosis of cataracts, or they're kind of in that realm of cataract time where they can wear that when they're outside to protect their eyes. And then there's some research that antioxidants, so some vitamins like A and B and E, can help out overall, maybe lessen the progression of cataracts. Now, glaucoma is a little bit different. So overall, glaucoma is a group of diseases. There's different types of glaucoma, but articles and researchers kind of agree and disagree on how this works. But the overall idea, and we're going to look at the pathophysiology here in a second, the overall idea is pressure increases, okay, because we're making aqueous humor, we're making this beautiful fluid that our eye likes, and either it can't get absorbed for some reason, and it builds up pressure. That pressure starts to push on that optic nerve and cause atrophy of that optic nerve, and then our patient, because of that, has issues with vision. So glaucoma is really, like I said, a group of diseases, but the two most common we're going to see is primary, or called open glaucoma, okay? And then we also have our angle closure glaucoma. Those are the two most common. Out of those two, our primary open angle glaucoma, or open angle glaucoma, is the most common, about 90% of our cases. And we're going to look at why they're different and how they both cause issues. But either way, they're usually causing an issue relatively of increased intracranial, different video, intraocular pressure, or some kind of damage to the optic nerve, whatever it might be. Now, some other risk factors, though, are patients that are older, African-American race can increase your risk here. Also, patients that are chronic smokers, possibly patients taking chronic steroids again, any of those things can increase our risk for glaucoma. So when we look at our primary open-angle glaucoma, we know that we're making our aqueous humor from our ciliary body. Our ciliary body really helps, one, structure of keeping that lens there, but it also gives that nice humor. The lens loves that, and so does the eye. A lot of good nutrients in that fluid that the eye wants. Well, the issue is here is we're making all that nice fluid, and then it's usually reabsorbed here at this meshwork. That meshwork, for some reason, is clogged, whether it's the makeup of the cells or whatever it might be. It's kind of like your clogged sink, right? You open up your faucet, fluid's coming out, you clog your sink, overflow, overflow, overflow. Same thing kind of happens here, but instead of overflowing and like tearing it all out, it has nowhere to go. Therefore, the pressure in the eye increases a ton, and then that puts pressure and damage eventually to the optic nerve. That's kind of the idea of how this works, which then causes issue with vision. So this is the most common way to happen. The other way is a little bit different. So when we look at angle closure glaucoma, it's more of like an obstructive, I feel like a mechanical obstructive almost, where like the lens is going to be sitting more anterior, right? So it's pushing more up towards our iris. So now this is a normal eye over here on the left when we're making our aqueous humor. Here it goes, get reabsorbed, all great. But on this guy, he's creating this obstruction. He's kind of creating all these issues. That's what we call kind of angle closure, because that angle in there between our ciliary body and really of our lens and everything in that anterior chamber is closed, right? Because that lens is physically pushing forward, so we can't even get the fluid to the actual meshwork where it needs to get absorbed. Either way, both are causing issues with the fluid. Both can cause visual disturbances. So subjective and objective data, it's kind of difficult because with chronic glaucoma, patients will have no signs and symptoms until later progression, right? That's also why it's hard to treat, because even if they have objective data that we see or diagnose, they might be like, well, I don't feel anything, so why am I taking the meds? So subjective data, relatively how this works though, or how it goes with chronic, is they'll start to lose issues with their peripheral vision, so they'll start to have issues there, and then eventually their central vision. Now that's chronic. Now acute, which is when we have a good spike in the interocular pressure, like up in the 30s, 40s, 60s, sometimes, that can cause actual signs and symptoms, like they might have headache, nausea, vomiting, visual acuity disturbances, their eye themselves, right? They might have erythema, watery, pain in the eye itself. So that's obviously an emergency. We usually give those patients like mannitol, which is osmotic diuretic, pull that fluid off, Diamox, stuff like that. Objective data, you might not see anything at all, unless maybe it's acute. Diagnosis. Now, the American Academy of Ophthalmology and UpToDate and other people usually agree relatively the age of 40 is when we should start screening for glaucoma. And then the frequency and how often you want to do that for your patient is really kind of based off of their risk factors, right? How high of a risk do they have for glaucoma? Are they having any signs and symptoms right then and there? And then your frequency kind of changes up. But really, the age of 40 is when we should start looking for this. Overall diagnosis, though, obviously increased ocular pressure we can see. Not all the time, though. 10 to 20 is normal. Some people that have primary glaucoma, they might be living in a normal pressure, but they're still having issues with the optic nerve. But patients usually will have increased interocular pressure. Other things, though, is going to be a more detailed exam by a trained ophthalmologist, and they're usually going to see some of the atrophy in the back on that optic nerve. Treatment, there are some surgery options, but a lot of times medication can be some of the first-line treatment. So it's really aimed at either creating less aqueous humor, if we create less fluid, less chance for it to build up and cause increased pressure, or let the fluid come and we'll just either reabsorb it better or figure out a way to just bring it back into the body, okay? So some mainstays are like beta blockers, so like timolol is a good example. Beta blockers help decrease the amount made. Some issues though with the beta blockers is they're still kind of giving us some systemic effects, not on all patients, but they can. So even though we're topically giving it, they can absorb it systemically and cause all of the issues that we know come with our beta blockers, whether it's selective or non-selective. Some things patients can do to help that sometimes is telling them to put the drops in, close their eye, keep it closed for 3 minutes, and then kind of push on that eye and hopefully increase the topical absorption and decrease the systemic absorption. Some other good drugs that are getting more popularity are prostaglandin analogs, and those guys overall help increase the absorption of this fluid, and they do that by kind of relaxing the ciliary muscle, and therefore it brings that fluid in better. So overall, what we're just trying to do, the mainstay of treatment, is just decrease intraocular pressure. There's a ton of other med classes here. These are kind of just the first two most popular. That is all I have for you guys. Please comment with any questions. Like the video if you did. I'll see you next time. Good luck.